Congratulate Dr. Bundela for that, and he has organized this really well. Before I start the topic, how in the market, and everybody really wants to learn what are these drugs about and how they can help me lose weight. So before I start the talk, we must understand what is obesity and how it is affecting our lives to understand what are the treatment options for obesity. So we took 1 million years to evolve from this to this, but in the past 100 years we have evolved from this to this, and that is what is the problem. So in India, where traditionally we thought obesity is not a big problem, malnutrition is a bigger problem, what we have seen is now it has become a very big socio-economic burden, with 2 billion adults are obese and 70% of them are residing in low income or middle income countries. So India is at a very bad shape with higher prevalence of obesity and higher prevalence of abdominal obesity. So हमारी क्या आती है? Don't. So that is a big problem for us. Not only obesity, we are dealing now with an epidemic of obesity, diabetes and MAFLD. These are 3 chronic diseases and now have developed into 3 pandemic. All of them have 2 things in common. They are poorly managed, and that is why are increasing in prevalence. So for such a chronic disease, what are the treatment options that we have? So the treatment options vary from lifestyle management, gym, diet, exercise, medications, to surgical procedures and also endoscopic procedures. But what is the problem is, surgeons have been there for a long period of time, but patients rarely undergo surgery. Even obese patients who are morbidly obese don't want to undergo surgery. So an ideal treatment for obesity should be organ sparing, should be safe, effective, should not have any long-term consequences, and should have minimal disruption in anatomy. So the first things that came were drugs, and drugs are not new. They were available since 1999. So I don't know if a lot of people who were practicing in 1999 actually started or did use Orlistat. In fact, when I did my DM, I never used Orlistat. But nowadays, people are starting to use Semaglutide, Tirzepatide, and newer drugs in market. So what has changed? So understanding drugs, we need to understand what makes us obese. So what is the pathophysiology of obesity? And you can see it's a very complex diagram, and I was very poor in that. So I simplified it for you. So there are 2 main regulators, GIP, peptide YY, and glucagon. And hunger signal, which tells you, you need to eat. You get up in the morning, you have to have breakfast. So hunger signal is ghrelin. So the drugs of weight loss act on these hormones only. And the newer drugs, first one was Semaglutide. So it was a GLP-1 agonist. So it acted like GLP-1. It told you you are full, you don't need to eat. So the study came in NEGM, it showed that it has a good total body weight loss. So 15% total body weight loss at 2 years. Then came a newer drug, which is Mounjaro or Tirzepatide, which said, let us focus on 2 satiety hormones, GIP and GLP-1. So it caused even more weight loss. And now a new drug which is an agonist of 3 satiety hormones, GIP, GLP-1 and glucagon, ritutride has come, which causes even more weight loss. So we have drugs, we have trials which show that they cause more weight loss. So now we have a drug, a wonder drug for obesity. India today seems to think so, that we have a wonder drug for obesity. But is all the things positive about the drug? Let us see what are the limitations. Why, despite these drugs available and a lot of people knowing and using it, are actually not losing that much weight? You see, the patients are using it, but coming to you that I did not lose that much weight that I anticipated or that the trial showed. So what happened? What was the problem? The problem is intolerance. A lot of these drugs have GI side effect. Because they make you feel full, they also make you feel nauseous. You feel nausea. You don't feel happy. Also, the weight loss is not proportional. It does not only lose fat, it also makes you lose your muscle. So muscle is good. Muscle is very important. And actually muscle loss is now a bad prognostic factor in almost all the diseases. I see physicians, you deal with cardiology, you deal with nephrology, you deal with normal general physician, and a person who is weak looking with low muscle mass has a bad prognosis in any disease that you deal with. So what happens is it leads to loss of muscle also with fat. Third is cost. You need to take the drugs for long period of time. So initially it might appear good that you are taking a drug for a less cost, but over time this cost multiplies. Also, how long will you take? You can take for 6 months, but then what will happen? So the problem first was durability. So this was a trial that I showed you initially in any gym. What happened? If you don't give anything, you don't have any weight loss. You can see my cursor. If you give the drug, it leads to a good weight loss. But at this point of time, because the trial was over, they stopped giving the drug. And what happened? That those patients who have had weight loss actually started to have weight regain. So if you stop the drug, your weight again increases. So this is very, very important to understand and tell your patients, tell your relatives that this works only till the time that you take the drug. Why it works only till the time that we take the drug? Again, coming to this diagram, you can see that this pathology is very complex. And there are multiple mechanisms to do one single thing. And that is why once you block one mechanism and you stop the drug, the other mechanism takes over and makes you feel hungry, and subsequently you actually overeat after stopping the drugs, and you tend to gain only the fat back, not the muscle back. What about the safety? Whenever new things come to the market, the first thing is asked, is it safe? Boss, it might work, it might not work, but is it safe? So a lot of them have GI side effect that I told you, that they have nausea. Okay, they can have nausea. 90%, all of them. So if somebody starts, you tell them, you are going to have nausea. So it is an anticipated event. However, in trials, 9 to 15% had serious adverse events. Also, you see, when a trial is done, patients are being monitored, they are being given treatment free of cost, the drug is being given free of cost. Still, 15% of the patients said, we don't want the drug. We have to stop the drug. So why this happened? Because a few of them had acute pancreatitis. That's a serious complication for a drug which is given for weight loss. There is now also certain risk of non-arthritic anterior ischemic optic neuropathy. So eye or vision loss with the drugs, especially in those who are diabetic. And why it is important is because a lot of obese patients are actually diabetic. I told you initially that a lot of obese patients have fatty liver and a lot of obese patients are diabetic. So you are going to find an obese patient with diabetes much more than you find a diabetes alone. So what happened is, this is trial, this is real world data. So they looked at 18,000 patients who actually started Tirzepatide or Semaglutide. And over 6 months, they found that 50% of them had to stop the drug. This was basically because of two reasons. First, it was very costly for them to buy the drug. Second, the side effects were very high, so they had to stop the drug. And we know that if you stop the drug, the weight will come back again. So they are far from perfect. So what are the other options for obesity? If the drugs are not perfect, then do I have anything else to offer? If the person comes to me with obesity, I should have something to offer. Surgery he does not want, and drugs he does not take for long period of time. So surgery he does not want, drugs he does not take. So now I have an option known as endoscopic option, which is known as endoscopic sleeve gastroplasty. What I do is, I use an endoscope, I attach this suturing device on top of the endoscope. The suturing device goes into the stomach, and there I take sutures like a normal surgeon takes sutures, but through an endoscope, and reduce the volume of the stomach. What happens is, once this volume gets reduced, you feel less hungry and then you lose weight. And this thing actually stays. So this is a real cut in one part of the stomach, go back to another part of the stomach and take U-shaped sutures. So if I take U-shaped sutures one over the another, I turn a bigger tube into a smaller tube. That is what you have to understand. So how does it work? So first, to understand how it works, we must understand what is our appetite. It is of two things. First is satiation. How much I will eat in one point of time. Somebody will eat 2 rotis, 3 rotis, other person will eat 4 rotis to get full. So that is what you want at one point of time. After eating a meal, you won't eat for some time. How long you won't eat is known as satiety. How long I will remain full after eating. So if I eat less and if I remain full for a long period of time, I will eat less in the entire day. That is the concept. So what does it do is, it reduces the volume of the stomach. You see a big stomach over here and you can see a small stomach over here. So you get full easily. So suppose you are taking 5 chapatis, you are now taking half chapati. And also it stays in your stomach for long, so you feel full for long. You don't want to eat again. So you eat breakfast, then you want to eat dinner. You don't want to eat lunch. So that is how it works. The concept remains good, but do we have data? So this was a randomized controlled trial. All the studies, the best study is the randomized controlled trial. So you give one arm endoscopic sleeve, one arm you give medication, and you see at 2 years, when you do sleeve, you have weight loss and improvement in comorbidities. So not only weight loss happened, diabetes improved, hypertension improved, dyslipidemia improved. So that is very important because the person is suffering from all these diseases, not only weight. They were highly satisfied, extremely safe, only 2% adverse events, and this was backed up with a meta-analysis. Meta-analysis is even higher. They look at all the randomized studies and they found that there was a weight loss and there was very less adverse events. Not only this, they helped. We were looking for gallstone, but we have got a fatty liver. Not only it helps in obesity, it helps in fatty liver improvement. And not only fatty liver, sometimes fatty liver goes into what is known as cirrhosis. So it can help in improvement of NAFLD or metabolic associated fatty liver disease. Previously it was called as NAFLD, and it can lead to improvement in that. This was also proved in a randomized controlled trial recently proven, which showed there was resolution of NASH in patients who underwent this procedure. So we have experience of this procedure. We have a randomized controlled trial. We have publications and participants in randomized controlled trial. We have an established procedure which is backed up by American Society and European Society of Gastroenterology, with the potential advantage that it is safe, it is effective, it is adjustable to the patient needs, it is reversible if needed, it is minimally invasive, does not require any cut because it is going to the mouth. It has favorable impact of comorbidities, thereby more acceptable to the patients. Regarding cost, if you look at the long-term outcome, if you look at 2 years, drugs are actually costlier than the procedure. So what is the airline management of obesity? The question was, what is the airline management of obesity? Now, airline management of obesity is probably a combination therapy. You might need an endoscopic procedure, you might need some drugs, depending on what the patient wants. So GLP-1 receptor, like Semaglutide and Mounjaro, are far from perfect. They will lead to more patients thinking that yes, I need treatment for obesity, but might not help all of them. Endobariatrics, on the other hand, will have a role in those patients who are not losing weight with GLP-1 or are having side effects with GLP-1. Thus, we need newer technology and combination therapy because, you know, obesity is a obesity.
Being cardiologist, I have experience of few patients about the Mounjaro. Although it is not very long term, at around 4 to 5 months I have been using this drug. So as far as the side effect that we study or that we read in the book, and we have very much fear about the side effect and the nausea about it. And actually it does not happen so much in the real practice. But the long-term effect, as you said, that once you have stopped this drug and the reboundly, again the patient will increase in the weight. So it is happens, but I do not have that experience. So it is I have read. But one thing I know that as the time passes, and the market price is, and initially when it came into the market, it was around 18,000. So price about half has reduced. In the near 1 or 2 years, the price further reduced. So the cost effectiveness will come to the for every patient. And as far as the side effect, the two side effects, the acute pancreatitis, or one thing that I add to the patient that doctors those are using this. So you should get your ultrasound before using this, because the many patients are because of having the low appetite, they are developing gallstones. So you should rule out the gallstone before using this into the practice. So one more thing I want to ask about the long-term demerits of this endoscopy procedure.
So, very well point raised that the drugs are getting cheaper. Yes, they are, and definitely they will get more cheaper as the new companies are coming into market and the patent is getting stopped now. Semaglutide is, I think, off patent. But the problem remains the same, that patients consider these drugs as one-stop solution. So, I am on this drug, let me go anything, I don't need anything else. I just have the drug, it is going to be a magic pill. It's not a magic pill. So any treatment for obesity, actually I did not have time to go into that, but any treatment of obesity is a multidisciplinary approach. It starts with diet and lifestyle. So these are not substitute for diet and lifestyle. A lot of people think these are substitute for diet and lifestyle. You tell them you have to walk, you have to eat healthy, and they say, no, doctor, give us drug. We don't have time for walking, but give us the drug. So that's not going to actually help them. So that is one thing that you have to tell them, that they are not substitute for the drug, diet and lifestyle management, and they are complementary. So diet and lifestyle will go with the drug. Second of all, the side effects are very low at 2.5 mg doses. I think your patients were on 2.5. As you increase the dose, because you will need to get good weight loss, you will have some side effects like that, and you need to anticipate and treat them. The third thing is, there are certain basic things that you can do, taking the drug in the morning, having the breakfast 1 hour after taking the drug. These are the things that can help if oral semaglutide is given, that can help us. The side effects of endoscopic sleeve gastroplasty in the long term are not very much, because this is a procedure. This is an endoscopic procedure. Mostly you get side effects if they are on the day of procedure. You have some nausea and vomiting, which gets subsided in 24 hours. The long-term side effects are actually not there, because the long-term, this does not have any altered bad metabolic effect in the body. Only thing is, as all obesity treatments are, there is weight regain after 2 to 3 years if the patient does not follow diet and lifestyle modification. That is absolutely essential.
One more thing, what is the success rate of endoscopy process? How many times you got failed or you did not get the result as you expected?
No, there are technical success and clinical success. There are two aspects to a success. Technical success, almost everybody can get a good technical success. It's easy. It's not very tough to do it. But clinical success actually depends on patient and you, because the diet has to be followed by the patient. So you give a diet chart. If the patient does not follow the diet chart, it's not going to work. That is why you need to first counsel the patient that, boss, I am doing this procedure for you, but it won't work if you don't follow this diet chart. You just see the diet chart beforehand. I do this. I make sure that they see the diet chart, they understand the diet chart, and then they go for the procedure. Otherwise, they will come back and say, I got the procedure yesterday, I've gone to a wedding this weekend, can I have a cholo bhatura? And then you need to understand that this is not going to work.
One more thing, I want to ask you, what kind of patient, those who have already taken Monjaro or they have got default their treatment, so you would suggest or you directly suggest them to who have the BMI more than 30, what kind of substitute you actually ask them?
So the patient selection, that's a very good question. So when we divide obesity, we divide into class 1, class 2 and class 3 obesity. So obesity endoscopic treatments are suggested for class 1 and class 2 obesity. BMI 28 to 40. Body mass index between 28 and 40, and 28 to 30 usually with comorbidities we take, and 30 to 40 we take. So these are the patients you really need to go for endoscopic treatment for obesity.
Thank you.
One thing.
Do you have any cost? So we would talk about the reasonable costs.
Thank you, Dr. Shah. Just one question. So even the ASMBS has suggested that endoscopic sleeve should be restricted to low BMI patients.
Yes.
So in high BMI, you think the effect is suboptimal, or you feel there's a technical difficulty in those patients?
No, the effect is suboptimal because the weight loss is 20% of total body weight loss. If the patient weighs 250 kgs, that would give you a 50 kg weight loss. He again weighs 200 kgs. So I don't want a patient weighing 250 kg to weigh 200 kgs. I want him to weigh around 150 kg. That degree of weight loss is given by a malabsorptive procedure. That would be a bypass for it. So very important to understand that these procedures are not competitive. They are complementary to each other. But suppose this patient also has an advanced cardiac disease, he also has a kidney disease, he cannot be in GA for a long period of time. Maybe 10-15 minutes, or he wants to be in TIVA. The anesthetist says, I cannot give GA for this procedure, bariatric procedure. Then what we can do is, we can do a bridge procedure. We can do an ESG or a balloon, give him around 6 months, he loses some weight, and then he can go for a definitive procedure. So these are all complementary procedures, and obesity is a complex disease with there are many ways to skin a cat. So you can use a lot of ways to treat obesity.
Yes, because the gold standard seems to remain the surgical, and as you rightly pointed out, the patients who are requiring surgery, only 1% of them are opting for surgery, despite the fact that now the mortality and morbidity rate of the geosurgical procedure is less than what you do get in a laparoscopic cholecystectomy.
Not less than, but equivalent, I think.
Round about 1%, or more than that, in good centers.
So actually the problem is, one bad case ruins the reputation of the entire procedure. So if you have had a sleeve leak, the entire city would not undergo a sleeve. They would say, no, this patient was well, he was alright, he was walking, he was not having any problem. The doctor convinced him to have a sleeve gastrectomy. There was a leak, and now look at him, what happened to him.
We are getting good results, but still long-term data is still evolving.
Yes.
And number one, number two, health, lifestyle modification is still the best. You have to follow them, despite this.
Yes,
That
definitely.
is both with medicine and surgery. Anything lifestyle modification has to be there.
Has to be there.
Otherwise, failure will be there with both medicinal and surgical. That's to be there.
Thank you so much, Dr. Saranssh Jain, for a wonderful lecture. As we are